Firstly, thank you, Munir and Christine, for the kind invitation to talk today. So I'm a general practitioner or a family medicine physician in Surrey. We're in a semi-rural practice. I have 11,500 patients, 2,300 of which are registered with me. And on a busy clinical day, I could see or have 60 patient contacts, which includes telephone and also face-to-face consultations. So I'm a convert to genomics. Recently I've done the Masters in Medical Genomics, which was funded by HEE, and I'm very grateful to HEE for funding me. And I particularly enjoy dressing up in a white coat and using pipette and making DNA, which is really interesting, but I haven't done that in practice yet. But the view that I'm going to give you is really more of a pragmatic view of how genomics may be implemented in primary care. So, teaching Broadway Underground Station, I've got a notice board that their staff set up for their thought of the day. And the thought of the day for yesterday was, when thinking about starting something new, consider what to stop that's something old. And I think that's particularly apt, in general practice with our current pressures. So the something new is all about stratifying and personalised medicines. The something old is reducing the drugs budget, reducing predictable adverse effects of prescribing, and reducing A&E, or helping to reduce A&E admissions. In terms of why it's quite important that we consider pharmacogenomics in day-to-day practice is to help us with our patients, and particularly managing multimorbidity and polypharmacy, which I'll define in a moment. And around that are all the issues of patient safety and helping to promote patient adherence. So in a typical week, for example, we may authorise 200 repeat prescriptions. And you can imagine, this is ripe for medication errors. Similarly, patient adherence, we obviously deal with reactive care, but a large proportion of our time is dealing with long-term chronic conditions. And this is the sort of patient dialogue we need to have about adherence of medications. In support of what we do on a day-to-day basis, we have the electronic health record, which is really powerful in general practice, and we have decision support. So many of our systems, IT systems, have prescribing decision support that helps us on a day-to-day basis with our prescriptions. So in terms of multimorbidity and polypharmacy, there's been good evidence that the more drugs you prescribe, the more error rates you have. And this particular report, which was commissioned by the General Medical Council and led by Tony Avery, if patients are on more than 10 medications, then this study showed that 47% of these patients had prescribing or monitoring errors. So 47% of these patients on 10 or more medications had prescribing or monitoring errors in a 12-month study period. This study from Bruce Guthrie from Scotland was a cross-sectional analysis of prescribing in primary care, and he demonstrated that 13% of patients were prescribed high-risk drugs in the study period that they looked at. So multimorbidity is defined as 2 or more chronic conditions and associated with polypharmacy, which means individuals being sometimes on more than 10 individual drugs. There's been really good epidemiological work done in Scotland, particularly by Bruce Guthrie and Stuart Mercer, who have looked at comorbidities. And there are links between various diseases, as you would expect, so diabetes, cancer, coronary heart disease, and so on. But the other important factors were the link with social deprivation and the fact that many of these patients who had multimorbidity were young patients, so under the age of 65, and not the elderly frail that you would normally expect. So really important study. And the difficulty, though, is that for each of these conditions, there's evidence-based drug prescribing. And And this is the challenge of management in primary care. And to date, there's been little strong interventions that are helping us deal with these type of patients. So as an example of where we could run into problems, if we have patients who we need to manage and control their pain for whatever reason, who might have chronic obstructive pulmonary disease, who might be on codeine, we get prescribing alerts to say, please don't prescribe codeine in the presence of COPD. And the reason, as evident from the pharmacogenomics, is the fact that if you're an ultra-metabolizer of codeine, you're going to produce high levels of morphine and be susceptible to respiratory depression. But here's a correlation between two diseases and one drug. However, what would be really interesting is, and what's been said a couple of times this morning, is modelling what happens when you put 10 drugs together. And I'm not sure that we've seen much evidence or any work really that's helped us look at that. So perhaps, Nadine, that's the next research project. So in terms of patient adherence, there is this meta-analysis that's been done that actually tells us that actually patients have a menu of drugs that they like and don't like. And so, for example, 46% of patients on statins stopped taking their statins based on their perceived potential side effects that they were getting. And similarly for hypertension and for aspirin use. We have national guidance on patient adherence and also medicines optimization. And it covers themes such as involving patients in decision making, reviewing medications, communication between healthcare professionals. NICE have also made a statement about decision support in the medicines optimization guidelines, and highlights the importance of safety, and particularly around the importance of mandatory alerts for medicines never related events, such as prescribing penicillin when there's a clear allergy notice that says this patient is allergic. The fact that the decision support should have the best available evidence and that it's relevant to the healthcare professionals, so that they're not just getting alert fatigue, but it's actually relevant to practice. And so it's really important, I think, that there's ongoing surveillance and monitoring and literature reviews and meta-analysis of how good clinical decision support systems are, particularly relevant to pharmacogenomics. So this is a position we want to be. We want to move from, to a state of stratified medicines, personalized medicines, using the technical advances in genomics and using our diagnostic and predictive testing. So if we think about a little checklist for implementation in primary care, I think the most important thing to consider, first of all, is the environment in which we're working in. So there's a national strategy paper, the GP Forward View, that is over the next 4 to 5 years, is looking to see how primary care can be strengthened based on the current workload pressures. And the RCGP have made a clear statement that there needs to be increasing funding, increasing a workforce, which includes not only GPs but other members of the practice team, and that this needs to be done quite urgently. The GP Forward View and the mechanism by which it's going to be implemented is through the sustainability and transformation partnerships which are being set up around the country, so-called STPs. And the STPs are going to be sort of collaborations between NHS trusts, secondary care, primary care, community services and mental health services. So I'm not quite clear really where innovation fits in and how it will fit in and how easily the diffusion of innovation will happen. But perhaps it's going to be a region by region basis as to how that might occur. And I think that needs to be taken into account when we're trying to implement something around genomics. The RCGP have made a clear vision about how they see general practice working in the next 5 or 6 years, through their 2022 vision paper, which talks about the skills of practitioners in practice, which talks about funding, which talks about the workload pressures. So I just want to quickly run through these, the checklist that is provided by this framework that came out of Future Healthcare Journal. And the first is, has the evidence been considered and made for pharmacogenomics in practice? Well, we've heard a lot about that, I think, today and yesterday. And there's this gathering of data from the curation of gene variants into what are considered to be actionable prescribing decisions based on those gene variants. And we've got the Dutch working group, we've got CPIC, Pharmacogenomics as repositories of where these guidelines are, which will help us to implement, which is great. The other question is about the role of the regulator, and so there are many drugs now which have clear labelling suggesting the need for some form of genetic or genomic test. And yet I heard yesterday from Mary from St. Jude's about the fact that actually in the US it doesn't really happen, or it happens very little. So, can that not be used as a mechanism in which we can, drive pharmacogenomics into practice? And then ongoing evidence gathering, and in this country the National Institute for Health Research and its networks are looking to promote genomic research into practice, and we're working in primary care with Phil Evans, who's a GP here, who's the national lead, and helping to support the evidence. So the second thing to consider is what sort of model of, or how can we test people in general practice realistically? And there's been this discussion over the last two days about preemptive genotyping or against reactive typing. This particular study that I just want to highlight is one that was done in Canada, led by Professor Martin Dawes, who's a professor of primary care in British Columbia. And he's developed an assay of testing gene variants around pharmacogenomics, and set up this feasibility study, the primary outcome of which was to see if you could obtain and genotype samples from patients in primary care. And the secondary outcome was the yield and purity of DNA samples, which were then linked into a decision support software system that had been developed that could help in decision support using those variants. And what he found was that he was able, or his team were able to genotype close to 190 patients, and they were then entered into the decision support program. And 96% of these samples had at least one actionable genotype for medications, including in the decision support system. And this is the sort of report that you'd expect to see from a decision support system such as his. This one actually came from translational software, but basically, a traffic light system of highlighting the drug, the genotype, the response of the drug to the patient, and considerations around other guidelines and other drugs that could be used. And so it helps us to explain what we see in our prescribing decision support systems at the moment, where, for example, we might prescribe drugs like SSRIs, like citalopram, at high doses, where we get warnings about the potential for arrhythmias and actioning care after that. These were just some of the variants that Martin Dawes' team looked at and implemented. So the next aspect really is organisational buy-in. So what are the considerations that will lead to a practice, or increasingly a unit of practices? So we have what are called federations or GPs at scales, where we have a number of practices working together on various projects. So clearly it has to be relevant to practice, it has to fit in with the current workflow of the organisation. We would want to see an effect on workload in a positive direction. The fact that it should integrate with our current GP systems and electronic health records, the evidence. The fits in with the priorities of the NHS, and clearly there's a case here to be made that this is really important in reducing A admissions and reducing adverse effects, and consideration of the economic costs, and we've heard about economics today. It really needs to be resourced. So at the present time in general practice, we can't instigate genetic testing. We're not commissioned to do that. But there has been a clear signal from NHS England that testing will occur in general practice and it will be available to us. However, if we do start having conversations around consent for genomic testing, it's invariably going to lead to longer consultation times, which then has a knock-on effect on waiting times for patients and access to surgery for routine care. So any workflows that occur, so for example, post-sample waiting times need to be efficient, and it needs to be practical and timely. There's a current reconfiguration going on of genomic medicine centres around the country, and clearly they're going to be accredited laboratories which are going to be funded as part of normal NHS activities. Then there's something about leadership, and we have so the HEE funded courses. So for example, I've heard that there are probably around the order of about 20 GPs who to date have done MSCs, for example. We have over 50,000 members at the RCGP, and clearly there's a mismatch. So in terms of knowledge around genomics in primary care. So it could be that we start off with locality leads, or perhaps federation, GPs who work in federations who can take forward the work around genomics. We have genomic leads at the college, and the Royal College of General Practitioners Council have looked at 2 papers around genomics and looked at the impact of genomics and particularly some of the ethical issues relating to genomics. The Academy of Royal Medical Colleges have set up a committee, a intercollegiate group which have clinical champions for genomics. But the aim must be to encourage every GP to think about genomics as part of their routine care. But the other aspect also is to recruit other skilled team members into practice. And we have pharmacists now working in many practices around the country, and here's a potential role for pharmacists to work with GPs around their prescribing decision support systems. The next aspect really is about integrated care. So although I'm talking here about primary care, I think secondary care are in exactly the same position about the lack of knowledge around genomics. And here's an opportunity for us to work together across the interface. Particularly sort of having access to share data, about patients, I think would be really important. The other thing about, I've put the last point here about drug prescribing doses. I raised this yesterday about how our industry going to respond to the need to dose reduce, and are we going to have new dosing, new tablet strengths, that are going to help us to actually dose the patients at the right level. Workforce planning. So there's ongoing work, as I said, at postgraduate level, HEE, the colleges, NHS England, but clearly it needs to start earlier at undergraduate level. Having said that, most of us, when we leave medical school, forget everything that we've learnt because we're just taking on new skills. And I think postgraduate education really needs to have a really strong focus. We have a curriculum as part of the Royal College of General Practitioners on genetics, but delivering that genetic statement to trainees is hampered by the fact that actually trainers don't have a great deal of knowledge around genetics. So there's still quite a lot of work to do. The other aspect is about how people work in general practice. So I said I'm a GP principal, which means I'm responsible for the running of the practice, for the infrastructure of the practice. But we have many salaried partners who work with us, who have portfolio careers. They do lots of other things, which is a strength to the practice. So here's an opportunity to try and get them involved in something that's new and innovative. The GMC have also been looking at something called credentialing, and this is a process where you get a formal accreditation based on your level of competency around a particular area of work that's extra to your current day-to-day practice. The term we used to use in the past was something called, in general practice, GPs with a specialist interest in whatever that interest was, cardiology or dermatology. And it was about mentorship by a secondary care physician, about getting the necessarily competency or education requirements to help to deliver a service. So that's being trialled at the moment, and there was a trial around dermatology, for example, that has been published. And then processes and outcomes. So I think as time goes on, we clearly need, and as we start to implement this in practice, it's an iterative process in terms of efficiencies, in terms of value, in terms of working with our patients. So outcome data, I think, is particularly going to be helpful, not only in terms of patient adherence and benefits, but also, hard outcomes such as prescription errors and A&E admissions. But the other aspect really is the ethical, legal and social implications of genomics, and Nadeem raised the issue about socioeconomic and equity of access to testing, and I think that's really important. The sharing of data, both within the practice, between the practitioner and other family members is a key consideration, and also how the GPDR, the new sort of Data Protection Act, is going to help us in terms of sharing data with healthcare professionals. So I think pharmacogenomics has a clear potential value, I think, in terms of helping drug efficacy and reducing toxicity. It's innovative, it's new technology, but it must be implemented as part of normal clinical workflows. There's lots of activity going on in terms of how we mainstream genomics into practice, but I think one of the most important aspects is to take the patient with us and educate not only the practitioner but also the patient in what genomics means to them. Thank you.